Thank you, everybody, for joining us today. Today, we're here to talk about erectile dysfunction after prostate cancer. For many men impacted by prostate cancer, this is a real elephant in the room. It's a condition that triggers a deep sense of loss and grief. I'll be moderating today. My name is Matt Britland. I'm the president of a group called APA, which is a group of medical affairs professionals. We're all dedicated to drug development in Australia, but I'm also medical director at Amgen, looking after their genitourinary pipeline. So to help us understand the causes and the treatments and the problems with accessing care, I'm joined by urologist associate Professor Daniel Moon, nurse practitioner Francesca Rogers, and business founder and survivor Ken Bezan. When I looked at the CVs and bios for these three individuals, I decided not to go through them because they're so well qualified for today, and they've done so much. That I'll just leave that to you to read later, but they absolutely, it's a privilege to be moderating today. So run of play is all of our panelists today will share their insights and advice on managing erectile dysfunction with about 30 minutes of discussion, followed by 15 minutes of questions and answers. And I really do encourage you, please, to put your questions in. As I've mentioned, and we'll mention it again, this is an elephant in the room discussion. And some of the questions that you're maybe too afraid to ask are probably the ones that many people, many men are also too afraid to ask. And so please do ask them questions. To set the scene, the Urological Society of Australia and New Zealand, or USAMS, and the Royal Australian College of Physicians, the RACP, have just released Australia's first evidence-based clinical guidelines on the management of erectile dysfunction. And you can follow the links to this document. It's a really good read. So turning first to Dan, why do we need clinical guidelines on the management of erectile dysfunction, and how will they help the men in our audience today?
Hi, Matt. Yes, Daniel Moon's my name, and I'm a urologist. I've been treating predominantly cancer-based problems regarding the urinary tract over the last 15 years, but particularly centering around side effects such as erectile dysfunction. And it's a pleasure to be involved today, so thank you for the invite. What I would say in terms of guidelines is that there's been a lot discovered about the significance of erectile dysfunction and the role of various different treatment options over the last really couple of decades plus. And this ties everything together in a format that can be understood by men, their partners, by local doctors and other specialists as well, so that I guess we all have, terms of reference to assess and manage men who come from all different backgrounds with this problem. If men present simply with erectile dysfunction, what we would say de novo, which is where there's no obvious cause, such as a radical prostatectomy or other problems such as diabetes that affect nerve and blood vessels, then it's become apparent that erectile dysfunction is a bit of a red flag for doctors. And part of the guidelines talks a lot about looking into other health issues, not just in the urinary tract, but for example, if nerves and vessels are affected to the point where erections cannot start to suffer, what it tells us is that is generally a sign that the same process is happening to vessels everywhere around the body. And the next vessels to be affected are, for example, often the coronary arteries. So say a man just refers from a GP with erectile problems, say age 50 or 60. In fact, the erection can be one of the first signs that there's quite significant underlying heart disease. And clearly, that's something that needs to be appreciated. And so the guidelines also draw a lot of attention to the fact that men presenting with erectile dysfunction need to be treated as a whole, with a real holistic approach, which includes the assessment of risk factors for other health issues, which may even be immediately life-threatening. So that sets in place a set of diagnostic tests, which include cardiovascular tests, hormonal tests, important to assess for any reversible causes, and then progress to treatment options. And there's an array of treatment options and treatment hierarchies. And usually there's a way to get erections working some way or another in just about everyone who presents with this problem. And added to that, of course, overlying this is the inevitable psychological effects that go hand in hand. So it's quite a complex issue because you're treating then a problem that not only affects that person, but their immediate partners, their relationships. It can affect, anxiety, depression, stress levels, and that also needs to be taken into account because it feeds straight back into the problem itself. These sort of conditions lead to higher levels of things like circulating adrenaline, for example, when you're stressed, and that's the very drug we can use to turn erections off. So there are real biochemical issues or effects of emotional issues that tend to compound the problem. So going back to the guidelines, what it does is it provides a method, a clear, consistent method to assess men with erectile problems, to look at underlying contributing factors, reversible causes, and then provide a template for then offering a graduated treatment approach, starting with things like medications and leading up even to the point of surgery as definitive treatment.
Okay, thanks. And a couple of additional questions. I noticed the first evidence-based guideline, so it's taken a little bit of time to get here. Has there been a reason for that, or is erectile dysfunction coming to the forefront a little bit more?
That's a good question. I think any of these guideline panels probably meet too infrequently when it comes to these sort of issues. There's, I think some of the men's health we've seen have really lagged behind a lot of other health issues. The breast cancer foundations, for example, have been well ahead in terms of pushing for treatment and resources and understanding of management of other conditions like breast cancer. And it's unfortunate that men's health such as this perhaps hasn't received the attention or significance that it should have.
Yeah, thank you so much. Thank you, Dan. So we've clearly got a lot of work to do in this area to ensure equity, that all men get the treatment they need. Francesca, I'm going to turn to you as your role as a nurse practitioner. Can you tell us about what you see on the front line and how specialist nurses and other healthcare professionals help, but also a little bit more about the nurse practitioner role and whether there is enough nurse practitioners who are adequately trained in prostate cancer, for example, as compared to a disease like breast cancer, and maybe what next for nurse practitioners, because I don't know if too many people understand exactly what these roles are.
Yeah, thank you. I also just want to highlight the importance of the prostate cancer specialist nurses associated with PCFA, and I think that it's an important time to highlight the role that those nurses play in men who have got erectile dysfunction associated with treatment for prostate cancer. So, when you look at what PCSNs can offer, they're really that central point. So now with the introduction of the telehealth service through PCFA as well, every man now has access. So I think really highlighting the PCSN role and what that can do for men is really crucial here, because we've probably got a lot of consumers that, wonder who they can approach. So you've all got access to a prostate cancer nurse, whether it's locally, so at the site that you've had your treatment, but if you don't have a nurse associated with that site, you've got the telehealth nursing service. So phoning PCFA, speaking to the PCSN, that really gives you that first sort of central point and access to services available for sexual dysfunction. And, a lot of the nurses will actually have services available that they either do themselves or through that centre, or they will know the local services to refer you into. So I think always remembering that that's that point that you can go back to. There are some of the PCSNs associated with PCFA, other than myself, are nurse practitioners. And I think that understanding the role is helpful, and you've asked specifically. So a nurse practitioner is experienced in a specialty area. So they've done training in their specialty. So whether that's prostate cancer or urology or a totally different setting like general practice, and they've done a master's of nursing on top of that to allow them to have a slightly broader scope of practice. So to work, in coordination with other practitioners, nurse practitioners can assess and diagnose and prescribe and, provide sort of more holistic care. So that's what the nurse practitioner role is, and you'll find them in lots of different settings, and there are a few in urology. But I think that for this conversation, it's actually quite important to recognise the prostate cancer specialist nursing role through PCFA, because they're the people that these men have access to. And it's difficult for men to ask the question about sexual health. So I think that all of us as healthcare providers, whether we're working in a nursing role, a physio role, a medical role, if it's appropriate, you need to be asking questions around sexual health. So there's lots of studies showing that men are actually unlikely to initiate the conversation around it. So if you've got that rapport and you're in an environment where you can ask men, you need to be taking the opportunity to actually ask and then offer services or referral to services. And for men who aren't sure about where to go, you've got that sort of central point with your PCSN that you can go to. And yeah, really it's just about assessing that individual and looking at their level of bother as well, you know, looking at what they want to achieve and what they want to do. And I think that one thing we've all got to be better at is actually normalizing the desire to achieve erections and to look at treatment for sexual dysfunction for whatever reason. So for some men, it's about, you know, intimacy and actually re-engaging in sex. But for other men, it's just about self-stimulation or restoring a body part and just feeling like themselves. And I think we've really got to do better around normalizing that, you know, for whatever reason it is that they want to achieve erections, we facilitate it.
Okay, that's great. And again, I've got a sort of part B answer. You mentioned telehealth a little bit. So we've all had a bit of a crash course in digital literacy over the last few years with COVID. Healthcare professionals have got a different appetite for telehealth. Patients seem to have a different appetite. But how difficult is it to have these kind of very sensitive conversations within a Zoom like this or similar versus face-to-face in the confines of four walls?
I personally love face-to-face. You know, I think that you develop such a good rapport with people. So I try and do face-to-face when I can, but I've actually got personally, I've got a big pool of regional patients. So 30% of my patients are regional. So I've actually provided telehealth services for a long time. And, you know, it's effective. It's a good way to communicate. And I think that it also enables other family members or partners to be there as well. So, you know, you'll often have men who are still working or their partners are working and they actually can't both come in together. So sometimes a phone call or a Zoom is a really good way to be including partners. I don't know, Dan, how do you feel about Zoom?
We've all had to adjust to it in the last couple of years, whether we like it or not. And it's something that when it's done well and harnessed properly, it's opens up a lot of access for people. You know, it can be very, very good for people who otherwise may have to travel or not be able to attend appointments. It's great to allow multiple people to attend at once. I think it's a case-to-case basis. There's a lot of people, though, that really do prefer the in-person discussion. You know, so I think it's a tool. I don't think it replaces consultations, but it's a very, very useful tool.
Well, thank you, Francesca. Thank you also, Dan, for that. It's easy to see what a vitally important role the specialist nurses, the PCFA nurses particularly, and other allied health professionals play in promoting survivorship, which is quite amazing that we're talking so much about survivorship. But now turning to Ken, who has direct experience of erectile dysfunction. Ken, what insights and advice would you offer to others on this call?
Thanks, Matt, and thanks PCFA for inviting me along today. I just wanted to share my story a little bit, and hopefully people can relate to that. I was 59 years old when I was diagnosed with prostate cancer, and at that stage had a good, healthy sex life. So to me, you know, the diagnosis was pretty devastating because I was very concerned about the impact on my sexual function. And I discussed that at length with my urologist, and he ended up sending me to see a sexual health specialist before I had surgery. At that stage, they basically gave me some different PDE5 inhibitors to trial, and I found Viagra worked really well for me. So there was, you know, a bit of hope there, I suppose, at the end of the tunnel. I had the surgery 9 years ago now, and I remember on the morning of the surgery, the last thing I asked the urologist was to be careful of the nerves when he went in there. And he said, I'll do my best. And the first thing I said to him after I came out of the op was, how did you go? And he said to me, look, I'm really sorry, the tumour had grown near the surface on one side, and on one side I couldn't save the nerves for you. And hopefully the nerves on the other side will regenerate it and give you some function back. So I was a little bit devastated by that, but I worked through it, and I went back to see the sexual health specialist after the surgery. He trialled an injection with me, and just a low dose, and it worked. They trained me in how to use the injections and sold me the vial of little goodie to inject with. But what I found was that it basically gave me a fair bit of pain in doing that, and it took away a bit of spontaneity of sexual function. It became very medical, if you like. I was actually going into another room and injecting, and then sort of coming back and saying surprise. So you know, it really changed our sex life quite considerably. But I put up with it for a while, and then eventually I went back to the specialist and I said, look, I'm getting a lot of pain. And he said, well, you know, there's other things we can do, but you know, that's really the best I can do for you. And I wasn't too happy about that, so I looked at other specialists, and I sourced another sexual health specialist and went to see him, and he put me on a penile rehabilitation program. So it was a low dose Cialis and using a vacuum pump as well too, which was intended to obviously give some life back into the penis, get the blood flowing there, and to help in my recovery. As far as sex was concerned, the pump wasn't that successful for me. While it gave you an erection and you could put a band on to hold the erection, it became floppy at the base, and it was basically blue and cold, and not the most handsome thing to have a look at. Again, I looked at other things with him. The PDE5 inhibitors didn't work at all for me after surgery. So he said to me, well, look, let's try the injections again. And I use a compounding pharmacy, so we'll play with the formula, and we'll see if we can get it working specially for you, which we did over time. And going back, we did a number of different formulas, and eventually I got one that was working fairly well for me, although I still did have a little bit of pain afterwards. So that went on for quite a while. At 2 years after my surgery, I remember going back to see the urologist and asked him, you know, nothing was happening naturally. Do you think something would happen now? And he said, well, look, it could. It's unlikely, but it could. So give it a little bit more time. And at 3 years, he said to me, look, if nothing's happening now, it's never going to. And I remember leaving his rooms and feeling totally devastated by that outcome. That, you know, to me, having injections wasn't something that I really enjoyed. It had some complications. The erection lasted with me for over 2 hours, so you had to sort of plan the sexual activity. It couldn't be spontaneous at all. But it gave us some sexual pleasure. And in the end, I had a look around and I thought, well, what else can we do? And I was lucky because I was involved in a prostate cancer support group. I've run a support group now for 8.5 years. And we had some great guest speakers. We had some great people along, and I learned a lot about implants. So I decided that I'd have an implant. I'd go down that path. So I did more research. I talked to specialists and eventually found someone, and we had a good chat, including my wife in that process, which is a very important part of that. And it's a hard decision to make because it's an irreversible process. Once you've had the implant, you can't take it out and go back to normal. 4 years after my surgery, I had the implant, and it took a while, obviously, before I could use the implant. I think it was a 6-week period. But after that, it was like I was back in my 20s again. It was incredible. Our sex life was incredible. It was spontaneous again. It was like we were given a new life. It was totally different. With me, unfortunately, about 2.5 years later, the implant failed. It was just no fault of mine. It was or the product. It was just one of those things that happened. They tell me at that sort of time the failure rate was only 2.5%, but I had no hesitation in having it redone again. So I've had the implant in twice now, The last one's been in for about 19 months now. And again, it's changed our life incredibly. It's brought back into our life the pleasure that we enjoyed before the prostate cancer diagnosis. I'd certainly recommend to people to seek out support, to talk to people. I was lucky that I was part of a support group, that I went to conferences, I listened to our guest speakers, and I had access to their knowledge that they'd share. And if I hadn't been part of that, I really probably don't know what I would have done.
Wow, thank you. I mean, thank you firstly for the openness. I think, again, one thing, I mentioned this on a LinkedIn post, when when you talk about cancer of the prostate, it isn't really cancer just of the prostate. It is cancer of sexuality and confidence and mental health and careers and relationships and other things. So, I mean, it's great that you had this team to be able to make sure that they were never giving up. Hopefully, everybody's lucky enough to get that. But I'd love to get your thoughts on. You mentioned you did your own research.
Yep.
Would you just elaborate on that, because we've all got.
Sorry, Matt, I've lost you there. So hopefully people can hear me along the way. You're back again?
Yes, thank you.
Yeah, good. Yeah, I mean, it's not a matter of looking on the internet and finding the different manufacturers of the product and looking at the pros and cons and looking at all the chat sites and discussing with people what they had and what they didn't. It's really being seeking out a medical professional who you are confident in their ability, who can provide the advice that they need to you, and can recommend for you what's right for you. It's no use me going in and saying, hey, I found this thing online and I'd like one of those, please. It just doesn't work that way. It's great to talk to other people about their experiences, but we really have to put our hands in the professionals that we deal with to guide us and to provide the expertise that we need.
Matt, could I make a point on that as well? Ken, that's a fabulous story, and you've relayed that really well. And I'm really happy for you that through such a journey you're able to find a successful outcome. Everyone's different, but the important, Matt, too, is that this is not a cookie cutter thing. You can't get the algorithm from the internet or a Google search, because what has happened to you is very much different to what has happened to most other people. In other words, if we're just talking about radical prostatectomy, for example, the surgery is done differently in different men for different cancers for different reasons. So you could be spending a year or two diligently doing your daily Cialis and vacuum pumps and rehabilitating, but if your nerves are resected, it's not going to work. So you may as well be shown earlier what these other options are, so you don't waste a year or two of pretty much futile exercise. You need to know what has been done to you, the amount of nerve function available, pre-existing conditions, other comorbidities. All these things can predict the success and the outcomes of different forms of treatment. And it may be that someone like Ken or other people who we know are likely to get useful nerve function, they can be offered surgery earlier, because these definitive options such as penile prostheses, which are now the safest they've ever been. These have been around for 50 years or so. They provide a definitive option for erectile dysfunction. One of the problems with the other treatments is that it destroys all spontaneity and it makes it very clinical. And most men just find it so refreshing not to have to think about it anymore or pack the injections when you go on a holiday. And so to have this sort of procedure where you can get that back is really liberating. So I just needs to come into the conversation earlier, but my point is that you need to be seeing a specialist that is individualizing their advice.
Yeah, and before I got cut off, and I apologize for that. I was going to talk, I suppose, talk about Google and information versus misinformation, and how important it is to really work with your HCP team. I've got a couple of questions which actually loop into this, so maybe I'll ask Dan first. There's a particular question about side-to-nerve grafting and whether that's an option. And then there's another question from Anthony about what is an implant. So I was wondering, would you be able to just explain to the audience what is an implant and also your thoughts on side-to-nerve grafting?
That's a question to me, Matt?
Please, yes.
Nerve grafting is an interesting thought, and it's really still in what you'd say an experimental phase. There's a few specialists around the place that are trialing grafting of peripheral nerves, and it's a nerve that runs from your knee to your ankle that you can strip and plug one end into the femoral nerve, which is in your groin and supplies your leg, and the other end tunnel across into the penis. And you hope that this nerve provides new pathways for erectile function to be regenerated. It's a pretty interesting and somewhat radical theory, but there've been a group, I know at least one in Victoria, who've published their early results. It's a work in progress though, and it's not a small thing. It's a 4-hour operation. You lose sensation in your foot and it may or may not work. So it's an interesting theory, but it's a work in progress, I would say. In terms of the implant, this is a device that basically it's like putting in a tire. So you put your 2 inflatable cylinders, which are these things. They go into the penis in both sides, and they're attached to a pump that sits in the scrotum under the skin. Everything's internalized. Nothing can be seen from the outside. And when you want an erection, you reach down, you find the pump, you give it a number of squeezes, and that shifts fluid from a balloon that's tucked over in front of the bladder into the penis. So you basically pump the penis up, but you're pumping it up with a saline instead of blood. So it looks and feels like a normal erection. You don't quite get the length. That's the biggest potential issue. But after prostatectomy as well, you do lose some length. And this doesn't give you that back, unfortunately, but it does render what you have functional. And it's put in through a cut just in the scrotum, usually, or above the penis. There's a couple of different approaches. But you go home the next day and the device is a bit of healing to do and some learning to use the device. And then by 6 weeks, it can usually be cycled and start to be used after that. And as Ken has nicely pointed out, if it fails, which can happen, somewhere anywhere between a few years to 10 years, it can be removed and replaced. I work hand in hand with a specialist nurse, as Francesca has very rightly pointed out. This cannot be done by anything less than a team. And so I have a prosthetics nurse that works diligently with these patients before and after to really help them through this process and get their head around the new normal.
Yeah. And just one final question on the implant. Do you still see the sensitivity that you may have had before with the penis in terms of post-implant sensitivity?
Look, it's an interesting question because the nerves themselves are not affected. So we would say, well, I haven't changed the sensation of the penis. We're just making it firm. We're just providing a way to become rigid again. However, the head of the penis doesn't swell up like it does in a normal erection. So the perception of the man sometimes is it doesn't feel as sensitive. But I think it's just because of this, as I say, the new normal, because we're pumping up a shaft with more of a floppy tip on the top of the penis. And maybe that does provide the perception that there's slightly less sensation. But you know, strictly speaking, we haven't adjusted the nerves. It doesn't change the continence. It doesn't affect the quality of the orgasm. It just really makes the shaft hard.
Yeah. Okay. Well, thank you. Thank you so much. And again, thank you so much, Ken, for being so open. I believe that this needs discussing, and a lot of the reasons I think that people don't really understand and are not happy to talk about this is because it is a bit taboo, and I don't know why. It's one of the most organic things that we need in our life, and I really appreciate you talking so openly about this. I'm also very conscious, Dan, that we've only got 10 minutes more of your time, so I'm actually going to ask you another question in a second, if that's okay, because I know you have to go a little bit. But we want to open up the floor of general discussions around the panelists. We've spoken about the new clinical guidelines which apply to all men with erectile dysfunction, but is there a need for a specific set of guidelines for men with prostate cancer and erectile dysfunction? Again, Dan, I'd like to maybe get your thoughts on this first, and then maybe Francesca.
Sorry, what was the question there, Matt?
So do we need a specific sub-guideline, I suppose, for erectile dysfunction after prostate cancer?
Yeah. Well, there's this little subset in the guidelines here that talks about the evidence behind penile rehabilitation, which is what Ken has also spoken about. And for men who have undergone nerve-sparing surgery, then there is definite evidence that attention to a rehabilitation regime improves the chances of the nerves recovering. Exactly what that entails, we don't really know, because we don't have evidence to say what dose of what drug, how many times you should be using. But the principles are you should be using a regular oral agents such as Viagra or tadalafil, which is the generic version of Cialis. I tend to use that because it's long acting. You can use either a big dose a couple of times a week or a small dose daily. And that helps the nerves. You may not be getting erections, but there's still evidence that the nerves will be improved with that. And in addition to that, you need to get blood into the penis one way or another. So that can be with a vacuum device, say a couple of times a week or even daily, just getting blood in there just to keep it healthy. We know that if you don't get erections for a number of months, there's demonstrable scarring in that erectile tissue, so that even if the nerves do recover, the chances of you getting good erections back is less. So we need blood in there. That's why men get nocturnal erections. So either injections or a vacuum device gets the blood going and gives you a functional erection in addition to the tablets for the nerves. And then you make a decision. I see one question that says, I was recommended to wait. This is from Neil. Thank you. I was recommended to wait 2 years in case I get activity, even though I had no nerve sparing surgery. Could I request earlier? Absolutely. If there's no nerves there, then you've got to find some other way to move to get treatment. You don't need to wait the full 2 years, would be my answer. And that's my point about individualizing the advice. So as soon as someone's catheter's out and they're working on their continence, we start a pill, we look at a vacuum device or injectables, and then we take it every 3 months to see, depending on how things are recovering, as to what sort of regime we use and what advice we give from there.
Okay. And I'm going to just one more question to you, Dan, because I know you've got to go. This is quite specific. I think you might want to answer. We've had 2 questions about Peyronie's disease. Firstly, about how, it is challenging. Are there new treatments now or on the horizon? And also, can the implants be used if you have Peyronie's disease, which is not treated?
Peyronie's is a frustrating condition, and just when you think you're struggling to get the erections working, the nerves going again, the last thing you need is this sudden bend occurring for no reason. And that's what this is. It's a scarring that occurs on one side of the penis, that when a scar contracts, it pulls the penis one way, and suddenly you develop this curvature that can be minor, can be severe. And it's been a problem that has been difficult to find a solution to. There have been certain forms of injections that have enzymes that break down scar that can be used now, although they're not well funded. They can be quite expensive. There's no guarantee of effect. Ultimately, if you have Peyronie's disease and you have erectile issues, then the best treatment is an implant, because you can then incise that plaque, straighten the penis, and provide a way to get erections. So Peyronie's disease associated with erectile dysfunction is a good indication for an implant. If you have Peyronie's disease, but you're still getting normal, getting otherwise good erections, and it becomes a bit trickier. There are forms of operations to straighten the penis and address that plaque, but there is a risk of then harming the erections with some of those treatments. So again, that has to be individualized depending on the form of Peyronie's and the degree of angulation.
Okay, thank you so much. So Ken, this one's to you. So we're talking about elephants in room today, but let's talk about the elephant's needs in context of the health system that we're living in. Were many of the treatments, many of the treatments are not, available publicly, but what's been your experience? And in your view, what should we do about access to treatments, equitable access to treatments in Australia?
Okay. I suppose I was really lucky that I had a great GP and 2 good urologists and a good sexual health specialist to help me on my journey. But I found that many men just give up and accept the loss of sexual function as an inevitable outcome of their prostate cancer diagnosis. Most of them are worried about things like incontinence primarily, and they want to get that right first. And a lot of them take a long time to get that right, sadly. Many think that as you get older, sex is something that you learn to live without, and I've found that you don't have to. I think we need to make access to the specialists readily available. We need to educate the GPs a lot more so that they can refer appropriately. We certainly need to cut the waiting times for surgery for public patients, because it's nothing worse than a loss of sexual function. And you know that there's a cure there available for you, but you're sort of on the end of the queue. We need to promote further the access to the specialist nurses, like the PCFA, prostate cancer specialist nurses, and the telehealth service, so that people can be referred appropriately. And I think the main thing we need to do to help people along that journey is to provide mental health counselling conducted by people who understand, and that's sadly lacking, particularly here where I'm in WA at the moment. There's a huge waiting list to get public access to mental health.
Ken, can I say, echo those sentiments? That is absolutely 100% correct, Ken. Everything you've said there is spot on. But I put this as a challenge to the PCFA and every other lobby group that has any voice in this country. There is a two-tiered system for men who are treated for prostate cancer in this country, particularly around the management of sexual function. In the public system where I work in Victoria, there is a cancer centre that does dozens and dozens, if not 100, breast reconstructions after breast cancer for women. And this is a cosmetic operation, and have done 0 penile implants and have refused to do them for ever since it's been open, since I've worked there, for what is a functional disorder caused by the very treatment that patient is having in that hospital. It's a disgrace.
Yeah.
I'll also just comment on what Ken said about mental health support, because I just want to highlight that PCFA have launched the telehealth psychology service as well. Just to remind people of that.
Well, sort of on that subject was my next question, actually, to you, Francesca, about how we tackle this sort of stigma and the taboo. How do we make it okay to talk openly about things like not just erectile dysfunction, because that might be the tip of the iceberg, but that might cause depression, etc. But all of these are very, not a masculine kind of thing to talk about. You don't normally talk about it, but we need to change that. We need to turn that tide. So how do we do that? And have you found any strategies that work for different men within your hospital or the community setting?
Yeah, I think that, what I said previously about any practitioners that are listening, it's taking the opportunity to ask. So, I had a patient referred in by a physio. This patient had a prostate removal in 2008 and had never been talked to about sexual health or referred on. And the physio took the opportunity to ask and then refer him on. So healthcare workers need to do better at initiating conversations around it. And I think that what you said about men initiating the conversation, we keep talking about erections and erectile dysfunction, but we're forgetting all of the other components that come with prostate cancer treatment and side effects with sexual health, because men have to adapt to, potential climacturia, so leakage of urine, with orgasm or even just with arousal, and then loss of ejaculate. So we really need to be educating men around all of those topics and helping them to, re-navigate and adapt to changes in sexual health outside of just the ability to achieve an erection. And a lot of men don't have the words to articulate what's happening. If they haven't been warned, you may actually get a little bit of leakage of urine with arousal. I think they find it difficult to actually articulate what's happening. So we just need to be trying to help people to initiate the conversation and ask the questions that men may not think to ask or know how to ask. But I think, and Ken may agree with this or may disagree, but I've seen a big shift in men in the last 5 years, I think, where men are talking to each other a little bit more about sexual health and erectile dysfunction. And I think that comes from these great support groups and support group leaders who are helping to generate conversations around these things. So I do think that a shift is happening, but I think that men who are willing to communicate, like Ken, you keep doing so, men who maybe as well have done quite well with their treatment and their outcomes, they don't necessarily go to support groups because they don't feel that they need to, but maybe if they're willing to talk, it will help other men if they can hear from these guys. And just starting to facilitate that communication around, sexual health between men, but also we need to do better as as healthcare workers at initiating the conversation around it.
Thank you, Francesca. Dan, I know you got to go in a second, don't you? If I heard rightly. But I'm just wondering, do you have any other closing comments? And we're going to continue to talk with Francesca and Ken in a second. Do you have any closing comments today?
And I think it's been really nice to see the multidisciplinary approach that we have here. And Ken's really provide a really nice example of how the best results are when you have a good team looking after you. And so it really behoves all of us working in the field to make sure that we work hand in hand with nurses like Francesca, as well as our psychology colleagues and others, to give the best result and make sure we give all the options available. But if someone's, if you're struggling in this area, don't be afraid to seek another opinion and get the help that you need.
Well, thank you, Associate Professor Daniel Moon, for your time today. It's been phenomenal to have you here and your expertise. We've got a ton of questions, some quite clinically specific, so I'd probably recommend that you ask these back to your healthcare teams, because we might not be able to get through them all today, but we do want to thank you, Dan, for your time today.
Thanks a lot.
So I might go back to Ken and Francesca and just try and turn this into a bit of more of a fireside chat. We've talked about men all through today, right? Because we know that they're the ones with prostate cancer, but I'm interested in women. I'm interested in the female partners. What if they're the ones that want to start these discussions? What if they're the ones that feel this first? Do they have the ability to be able to talk to people, and I know PCFA does this, but could you talk about it, maybe Francesca, and then I might go to Ken about what your thoughts on this subject.
I always try and facilitate conversations with partners as well, so try and include them. And you asked about whether they're the ones that want to talk about it. I think that even in the instance that a couple is not actually sexually active and may not have been for a long time, it's really imperative to have that partner there at the conversation, because otherwise, if a man wants to pursue treatment and isn't actually necessarily sexually active, number one, do they want to be, and do they want to look at re-engaging, and then we need to initiate that conversation with them? Or is it just about normalizing to that partner that, hey, this person, for their own self-esteem, for their sense of self, and just simply restoring a body part, wants to go down this pathway. We need to help that partner to understand that, so that they're not concerned about, well, why are you doing this? Who are you wanting to do this for or with? So I think that when you've got a couple who may not be sexually active, it's just as important, if it's appropriate, to have that partner there. And coming back to couples who are sexually active, however they define that, it's crucial to have the partner there, because it's establishing what that couple wants to do and how they define sex, because you've got to really look at what treatment option is going to be appropriate for this couple with what they're doing or what they want to be doing. And some partners may be going through menopause, or premenopause, or during menopause, postmenopause, and they actually might have their own issues that need to be addressed to aid that relationship and the way they want to be having sex as well. So it's really critical to have them there. You've got to consider confidentiality. So if you are caring for the man, and you've mentioned female partners, but whatever the partner is, if you're caring for a man, obviously we've got to be careful as healthcare workers that you're maintaining confidentiality. If partners want to speak to the healthcare worker about the patient, you've got to be very careful around confidentiality. But I think that there are support groups for partners, so partners can talk to one another, and through PCFA they can access the prostate cancer specialist nurse and ask their own questions as well. But if it's actually going to the patient's practitioner, you've got to be careful around confidentiality when discussing the patient.
Yeah, that makes absolutely perfect sense. Ken, have you got any thoughts on this?
Yeah, we actively encourage partners to come along to our support groups, and quite often at the support group I see that it's the partners who are much more interested, not just in sexual topics, but in a lot of topics. And they'll grab the information, they'll talk to the people who present at the support groups, they'll ask the questions, and then they'll go home and discuss that in detail with their husband or their partner and drive them. And I think that's a big thing that we see all the time. Even when we go out and do awareness days and we're trying to make men aware of being tested for prostate cancer, it's the women that will come up to us and drive that activity. I'll take your brochures, I'll go and talk to my husband, I'll get him to the doctor. So they certainly have a big part to play. And look, I can't comment on everyone's partner, but I know from my partner's point of view, my wife's point of view, that she's been an important part of the journey. It's been an ongoing discussion from day one. Even when I was first diagnosed, I said to her, look, I don't really want any treatment. I just want to keep going. Life is normal. I'll put my head in the sand and we'll continue with our sex life. And she said, look, I'd rather you're alive than just to have sex. Life's more than just having sex. But now that we've gone through this process and we've resolved it, she's probably one of the happiest women that's around. She reckons the best thing that I've done, apart from marry her, of course. So, we tend to forget when we're going through our journeys as men, the role that our partner plays and how much they're impacted by it. And they certainly can help us a lot along the way.
Yeah.
Matt, while we're on the topic, of partners, I think we've just got to highlight as well that when caring for these men, you've got to look at also men who are single or who have casual sexual encounters as well. So, their treatment really needs to be very individualized, because it's what does this person want to achieve? What do they need to achieve in the situation that they're in? So, men who have got casual partners or are potentially looking at pursuing a relationship, we've got to consider how we approach those men as well. And again, normalize to them, getting a good plan in place, knowing that you can achieve what you want to achieve in case a situation arises that you do want that, casual encounter or look to pursue a new relationship.
Yeah, I think this is an important aspect of all cancer treatments. We talk about survivorship now, and we're talking about this because if you think about cancer now, more people actually survive cancer than die of cancer, which is quite an amazing statistic. We've got a long way to go, but and with an aging population as well, we obviously don't want treatments to have this like long-term impact on any, I suppose, activities of daily living, sexual function being any of them, if you're cured of a cancer, which is what everybody wants to do. I'm just going to skip to the bottom question here that's just coming about, quite protracted hormonal treatments have, a long-term impact on sexual dysfunction. Maybe Francesca, could you take that one? Could you talk about what advice you give to somebody on the long-term sort of androgen deprivation therapy?
I think it's really important, and I think that we often have patients who have had multimodal treatment. So you've got a man who might have had their prostate removed, and then a little while later they've had some radiation, and then they've gone on to hormone therapy. And it's very important that they understand what treatment has caused what side effect. So, obviously you've got the immediate onset erectile dysfunction with surgery because of the damage to the nerves. And then with radiation, it tends to be a much slower onset of erectile dysfunction over a few years. But with hormone therapy, it's a pretty different scenario, because whereas surgery and radiation, it's kind of the lights are on, but nobody's home. Whereas with hormone therapy, drive is diminished. So, their libido is lacking, they're tired, they've got lack of motivation, more emotional than normal. So men who are on hormone therapy have an entirely different set of symptoms. I actually work quite a lot with men who are on hormone therapy, and the approach to treatment is somewhat different, and you're looking at trying to actually re-navigate and learn how to be intimate again without that sort of automatic drive. So men tend to be quite visually and thought stimulated, so they've got that arousal followed by erection. And then with hormone therapy, it's just everything's kind of dimmed. So it's actually looking at, well, do we need to actually look at scheduling time for intimacy? So it's quite a different approach in helping men to re-engage with intimacy and re-engage with sex. And it's quite a foreign concept to most people to actually have to think about scheduling time for intimacy. And really, as people go through life, in not just in the prostate cancer world, but in any relationship, you'll have periods where you'll have mismatched libidos, or you've got external life stresses and other things going on. So for a lot of couples, and especially in the setting of hormone therapy, actually scheduling time and looking at intimacy is really important. And sometimes you've got to actually bring it right back and give people tools, like things like sensate focus exercises, where they're learning how to touch and learning how to be intimate again. But they need that specialist support. And that's where, again, the PCSN is an excellent resource, because they understand the treatment that person's had, and they understand what side effects they're getting and why, and how to help that person navigate through.
Thank you, Francesca. There's got a few more minutes before we close. There's a question about regional access, and again, in Australia, one in three of Australians live in remote, rural, or regional parts of Australia, and we have seen this connected with telehealth. Do you think, either of you, but I'll go to Francesca first, and then maybe Ken, do you think is there a disparity anymore, or do you think there is complete equity between rural and triple R access to information more than anything?
I think that it's, been evident for a long time that people who are in regional areas, struggle with access. And even if they do have access via Zoom and telehealth, it feels different. You can't just pop down the road and see someone. So I think that acknowledging the reduced access that people in regional areas have is really important. But also with telehealth services, they can pick up the phone, they can do a Zoom. So we can feel like we're interacting with these people more. And I did see a question in the group as well about regional services. And yeah, there are regional services. And again, telehealth has broadened everything. So I think that PCFA have actually got a really good list of specialist services for everything, sexual health, continence, psychology. So again, calling and finding out who's your closest resource. And I actually sometimes get queries for appointments with me from regional patients and patients outside of WA as well. And I'll actually look at, what resources do I have near them, and try and link them in with someone that is near to them. So there are people around. It's just about finding out, who's there and how to access them.
Yeah. And there's a whole load of questions about the fact that some patients just don't know about these things. They don't know about the numbers, and I'd really encourage anybody on this call to start sharing webinars like this, because the numbers carry through with the webinars. So we do need to get the word out, because not everybody is as articulate and as educated about this as somebody like Ken, for example. Okay, we've got a couple of minutes left, so I'd love to just get some closing thoughts. Maybe Ken, think about everything we've just talked about now. Have you got any additional thoughts on that? And what would be your one piece of advice that any man with prostate cancer or their partner could take from you today?
Okay, I think the most important thing, I've told my story, but everyone's story is different. Everyone's journey is different through this process. And what worked for me may not necessarily work for somebody else. You've got to look at your own individual circumstances. You've got to get the correct professional advice to help you on your journey, and not be afraid of going down that pathway. There's so much help out there available to everyone. The other thing that I'd like to mention too is through PCFA is the Mates Connect program, where people can connect with someone who's going through something similar to what they have been through. So I'm one of the volunteers that works on that program. And if people are going through and considering, for example, an implant, they can ring up through the Mates Connect through PCFA and ask to talk to somebody about it. And we can get really in depth about, what I've been through and what the pros and cons are, etc. So it's just one more avenue there for people to look for help. But reach out, get as much help as you can, learn as much as you can, and enjoy yourself.
Okay, I don't know if you've got maybe 15 seconds, Francesca, before we...
Yeah, I had a look at the questions in there as well, and there's a lot of questions around different injections and things like that. So what I would say is, there are a range of tablet medications. There is a range of different formulas with injectable medications. So there's comments about injections causing pain. Injections shouldn't cause pain. There's one medication that does. There are formulas available that don't have that medication in it. So just try and reach out to, your prostate cancer nurses, your local sexual health specialist, and talk about the various options. And we need to be just taking an individualized approach to each patient and looking at sexuality as a whole, not just being, erection focused, making sure that we're educating men about all aspects of sexual health changes with prostate cancer treatment.
Thank you so much. This has been an incredible hour. I think the 120 people listening, very grateful. I'm very grateful. PCFA, very grateful. Thank you to the whole panel. Thank you also to the corporate partners such as Amgen and Boston Scientific. A reminder that people can call, very important, number 1-800-220-99 for information, or go to www.pcfa.org.au to learn more. Again, I'd just like to thank the panelists. Thank you for the invitation to moderate this. It's an area which is completely close to my heart. And I wish you all a lovely day, and I look forward to continuing this really important conversation. Thank you to everybody for today.